Glaucoma UK is the charity supporting people living with glaucoma across the UK. We work across 3 areas. So firstly, campaigning and raising awareness, so fewer people go blind as a result of glaucoma. So that includes campaigns that we run through the year, including our Ramadan campaign, which is what this session is part of. We also run campaigns during World Glaucoma Week in March, in Glaucoma Awareness Week, which takes place in June, and also Eye Health Week in September. So there are a few of the times in the year where we run specific campaigns. We have advice and support services for people who have glaucoma to help them to stay well and live well with glaucoma. This includes our helpline, an abundance of information on our website. We also have an online forum where people with glaucoma can discuss issues and ask questions. We have free leaflets that are available to download from our website. And we also provide information and training for a number of professionals who work with people with glaucoma. So for example, eye clinic liaison officers and optometrists, and all of the services that we provide are free. Finally, we fund research so we can improve diagnosis, care and treatment for people who live with glaucoma. The most important thing with glaucoma is early diagnosis, and that way what we can do is make sure people have better eyesight for longer. Okay, as I mentioned, we run campaigns, and this week we're kicking off our Ramadan campaign. On the screen there are just a few images of some of the information we have available for people who are going through Ramadan and also have glaucoma. This information can be, along with a lot more information, can be found on our website. So if you're concerned about what time of day to be taking your eye drops, or if you struggle with your eye drops in general and maybe just want a little bit of advice on how to put them in, or if you're finding that your medication's making your eyes sore, we've got lots of information that can help you deal with those issues. So please take a look at our website. It's just glaucoma.uk, but right at the end of the session, I'll put that information up. Okay, and finally, one of the things that we have started during this year with COVID is our digital support groups. We've been running these since last summer, and we'll continue to deliver these sessions. We've run them on a whole range of different topics, and just in the corner there, you'll see that we are running we've got 3 more sessions that are coming up soon, and that includes on the 20th of April, driving and glaucoma. On the 5th of May, we're having a session again about glaucoma and eye drops, and this session is actually going to be in Urdu, which is the first time we've run a session in a different language. So we'd love people to get involved and give us feedback on that. And on the 11th of May, we have a session on living well with glaucoma. And we continually are updating these support groups and adding new ones. So just take a look at our website. You can register there and see what else we've got going on. So at this point, I'm going to stop sharing my screen there. And we'll pass over to Sally. So Sally, can I first just ask you to introduce yourself and maybe tell us a little bit about your work in glaucoma?
Sure. Thank you very much. And thank you for asking me to do this question and answer session today about glaucoma and fasting during Ramadan. So as you very correctly pointed out, I am a consultant ophthalmic surgeon and subspecialise in glaucoma at the Western Eye Hospital as part of Imperial NHS Trust. I've been in this post for coming up to 5 years now. I trained within Northwest London, so all of my training has been across the Northwest London region, including Moorfields Eye Hospital for a number of years. And essentially, the Western Eye Hospital has a mixed cohort of patients from lots of different backgrounds, whether it's religious or ethnic. And we do come across quite a few patients who have various degrees of glaucoma, and essentially offer them different kinds of treatments depending on what is suitable for the patient. So I am quite experienced in the use of whether it's topical medication or surgical options for patients when it comes to their management of glaucoma. But this particular topic is very close to my heart because I am myself Muslim and hoping to be fasting Ramadan starting tomorrow, inshallah. So I very much sympathize and understand where many patients come from, as a Muslim who probably started fasting from the age of 10, and during that period of time never really for legitimate quote unquote reasons broken my fast. I understand the patient's dedication and worry about doing anything that make their fasts invalid. So I do very much, like I said, feel very strongly about this topic and have a vested and personal interest, and very much understand why people would know more about it. And I would like to offer as much information as possible to help control their glaucoma, which is obviously very important, as well as reassure all the patients that their fasts and all their hard work and dedication to their religion can go hand in hand.
Brilliant, thank you. I mean, we really appreciate you coming along so you can share information with everybody who's, going through this situation, has got lots of questions and concerns. So the first thing I'm going to ask you is, so someone who is about to start fasting, they actually might be quite newly diagnosed, with glaucoma, and might not fully understand what the condition is. Could you give a little bit of information about what glaucoma actually is and what's going on in somebody's eye when they have that diagnosis?
Yep, of course. So glaucoma is actually a big family of diseases all grouped under the same title, and that sometimes can cause a lot of confusion to patients, especially when you are first diagnosed with the condition, and you usually come in and end up having a barrage of tests, and after being in the clinic for a good length of time, giving a rough bit of diagnosis and may not have the condition explained to you fully. But ultimately, in essence, the way I tend to explain it to patients is, imagine the eye as a camera system. So it's a complex visual system that's taken all the information from the world that it sees. And the optic nerve is the cable wire at the end of the actual eyeball that takes all this information from the eye to the part of the brain that will then go on to translate it as vision. That is the part of the eye that gets affected by glaucoma. The nerve gets damaged, and that can happen with or without raised pressure in the eye, and with or without symptoms. And actually, most of the patients tend to be asymptomatic. And as the nerve gets damaged, it is actually the field of vision that gets affected more so than the actual visual acuity. So, the way I illustrate it to the patients is looking straight ahead. The vision can stay at 20/20 or 6/6 for very, very long time, and in very advanced disease, the central part of the vision can remain at 6/6 or 20/20. It is actually the peripheral vision, so it's the outskirts that tends to disappear. And the sad thing about glaucoma till this date, because this optic nerve is an extension of your brain, just like brain tissue, it doesn't regenerate. So any nerve fibers that have been lost and any visual field that's already established at the time of diagnosis is irreversible. All the treatments that are available is to stop the disease from progressing, which is why we're always very keen to try and control the disease and catch it as early as possible to cause minimal impact on the day-to-day life of our patients. So in a nutshell, it's a disease of the cable wire. It tends to affect mainly the visual field, where the peripheral vision on the outskirts, when I'm sure lots of people can look on the Glaucoma UK website and see these lovely diagrams, tends to get blurry or disappear completely, and then it just continues if it's not stopped. And the only way to stop it is by taking some form of medication, normally starting with drops.
And what exactly are the eye drops doing? They can't heal glaucoma, they can't stop glaucoma entirely. Can you tell us a little bit more about that?
Yeah, absolutely. So again, imagine the eye is like a sink. So you've got a tap where fluid is being produced in order to keep the eye in the shape that it is and keep it pumped up. And then there's a plug hole through which that fluid comes out. Essentially in glaucoma, there's an imbalance in between the rate of the fluid production and the rate of it draining. So that can lead to the buildup of pressure. And like I said, that number, even though everyone talks about a specific number, which is 24 millimeters of mercury, is really arbitrary, because some people can have damage to their nerve with much lower pressures, and actually other people can have a very healthy nerve on much higher pressures. It's almost tailor-made to the patient, but ultimately there's an imbalance between production and drainage. So there is a group of drops, and that's, I think, again, where sometimes it can get very confusing when patients have been attending clinic for some time, because every time they come in, somebody looks at them and they are on one medication, and that medication is changed without very clear explanation. there's probably a group of 4 families ultimately of drops, and they work on either reducing how much fluid is being produced or increasing how much fluid comes out of the eye to lower the eye pressure. So even though we know that the eye pressure is not the only element that can cause glaucoma, at the moment it is the only thing that we can control. Normally, when we start treatment, we try and start with the least invasive drop, and that's least invasive in the sense of frequency of the drop. So a group of drops which is called the prostaglandin analogues, that is recommended by NICE and all the guidelines now by the Royal College of Ophthalmologists to be used as a first-line treatment. That includes Xalatan, Travatan, Lumigan. They only need to be taken once at night time before bed, so it doesn't have much of an impact on the patient's lifestyle. They don't have any systemic side effect, which some of the other drops can have, but they can cause irritation to the eye itself, and in most cases that tends to be temporary. So what tends to happen when a patient first presents to the glaucoma clinic, if they are diagnosed with glaucoma and advised that they need treatment, and it seems to be that for that patient, drops will be the first line treatment, then usually they are started on one of the family of those drops. Then you get reviewed in, again, depends on the severity of the disease and where in the country you are, usually within about 2 to 3 months, to see how effective those drops are. So whether or not they have worked in terms of lowering the eye pressure and you have been comfortable using them as a patient, because again, some patients may not get on with them, may not like them, and it could be anything from the drug itself to the actual bottle and the drop aids that may or may not be available for that patient to use. And then based on the disease progression, so you get always assessed not only by checking the pressure, but looking at that optic nerve and the cable wire and making sure it hasn't changed, as well as your visual field hasn't been any further progression. You either remain on the same treatment and you get followed up as regular intervals between 6 to 12 months, or the treatment is amended. And I think that's probably where a lot of confusion can happen, because sometimes the disease, again with glaucoma, even though it tends to affect both eyes, tends to be asymmetrical. So one eye may respond to the treatment better than the other eye. And then, some clinicians may advise to use different lots of drops for one eye and the other one. And you can see where the confusion can begin, because the frequency and the name of the drop. And then sometimes you'll be sitting at night and going, hang on, which eye's taking 1 drop and which eye's taking 2 drops? And this happens quite a lot. Or you would start on a drop and you're happy using it, and then you come in and you get told actually it's not enough, and then you get changed to a different drop with a different frequency or an extra drop on top of the one that you are already using. Or the third thing, which actually does happen quite a lot, is a lot of the patients that tend to present are completely asymptomatic and have no problems whatsoever. They have excellent vision, their eyes are very comfortable, they're very happy with their day-to-day living, and they get told, no, you need to take medication. This medication makes their eyes sore, makes it painful, makes it red. Sometimes patients can taste it at the back of their throat. And all of these things, especially if the condition hasn't been explained fully, can lead to non-compliance. So actually the patient not taking the drop because actually they've started off absolutely fine and you've given them something that's made them a lot worse, which is why I think is always very important to create a rapport and understanding with the patient, because ultimately it's very easy on the doctor's end to simply prescribe drugs and then just assume the person on the other end is going to take them without actually having any further information. It is always said that glaucoma is the thief of sight, because actually it takes the vision away without the patient knowing anything about it at all. And unfortunately, what can happen sometimes is the patient presents at a very critical stage where the disease is just starting to manifest itself and the patient becomes aware of it. But then at the same time, that's when the treatment starts and they associate the two things together. And they were like, well, I was absolutely fine until you started giving me all these drops and now my vision's getting worse and worse and worse. When actually, probably what was happening is they were just at that critical point and they were tipping over the edge anyway. And unfortunately, at that point, the topical medication was simply not enough. So that's why it's very important to very clearly map out with the patient where they are in the kind of severity of the disease, why we are giving them the medication that we are giving them, and why it is important for them to take it. Because again, the medication might be effective, but because they're non-compliant, the doctor doesn't know, and then they keep changing the drops, and that just adds more and more burden on both the patient and the hospital services, because that means they have to come back more frequently, more visits, more tests, more drops that they may or may not use. And ultimately, we're not achieving what we all here to set out to do, which is protect the vision and save the sight and prevent any further progression of the disease.
Okay, yeah, and it's a confusing one for people, isn't it? When they get all, you know, they might get lots of information from their doctor,
Yeah.
not fully understand it.
No.
And at Glaucoma UK, we're aware that a lot of people struggle with eye drops, whether they've just started taking their eye drops, or they're at the start of their treatment journey, or
Yeah.
also people that have been taking eye drops for a long, long time,
Yeah.
still struggle with them. And one of the things you mentioned at the start there was that the first eye drops somebody might be put on, you know, is just one eye drop in the evening.
Yes.
What would the progression be? At what times of day are people expected to take their eye drops if they're sort of maybe a bit further down the journey?
Yeah, so I mean, like I said, it depends on the family of the drops, and this is all evidence-based. So, you know, the reason why this particular family of drops has been prescribed to be used in the evening, and that's any time after 8 o'clock, so it's usually around most people's bedtime, is it just was shown to be more effective when it's taken at night time. Then usually what tends to happen, if that drop is ineffective, so it's just not lowered the pressure enough, or the disease is still progressing, we now thankfully have a group of what's called combined drops. So you can have 2 medications, but in one bottle. So from the patient's point of view, life continues on the same. They are still taking one drug at night time, although some of those medication, the combined medication, and they normally, the combination is with a beta blocker, something like timolol. It's been shown that the beta blocker element tends to work better if taken in the morning. So you might find is that you get told to switch your medication, the new bottle, even though it's one bottle, one drug, once a day, but instead of taking it at night time, you'll be taking it in the morning. And most of the time that's because now the new medication has, like I said, a group of drugs, which is called the beta blockers or timolol. So to give you an example, again, just going back to the point, it's just the way these work is, you know, you're working on either outflow or inflow. So the prostaglandins work on the outflow, so they make lots of fluid come out of the eye. The beta blockers work on the inflow. They reduce how much fluid you make. So that's why it would make sense to combine these 2 drugs together. Then if the disease again continues on progressing, then we move on to yet another family of drops that works in the same principle, but in a slightly different way. So again, it works on outflow, but through different channels, and lowers the pressure further. For me personally, normally that's where I would stop when it comes to drops, because I think if essentially triple therapy, so using 3 different families of drugs, is not effective, the likelihood of adding a 4th one is going to be very minimal to control the disease. And then it gets very confusing and very taxing to the patient. So then what would probably end up happening if we're ending up on the 3 points of drugs is you end up with having, hopefully, 2 bottles, 1 bottle to use once a day and 1 bottle to use twice a day. So again, not ridiculously taxing, but that is, for me, as a clinician, I normally don't go beyond that. So some people do then prescribe a 4th drop, and then you might find yourself taking drops in the morning, at midday, and in the evening, but they are 4 different bottles of different combinations and of different frequencies. And I think it just gets very, very confusing. And also, you know, these drops have their toll on the eye itself. You know, these are the patients that turn up with really red, really sore eyes, a lot of crusting around their eyes, and it just makes life very miserable for multiples of reasons. And again, very, very rarely is it worth going through that much for the IOP drop that you would get from that 1 drop, 1 extra drop, that drug that you're going to be adding to the eye. So normally that's kind of like the algorithm that I use. So I start with 1 drop that's once at night. If that's not enough, I combine it with a beta blocker, and then it'll be 1 drop in the morning. If that's not enough, I then introduce a 3rd medication, and it'll be once in the morning, and then essentially 2 drugs at night time. And then that will be it. If at that point is not effective and the glaucoma continues on progressing, then we are considering surgical options or laser options. So slightly more invasive forms of treatment.
Yeah. And with those different eye drops that patients might have to take at various times during the day, Does it matter what time they take them? Is there a certain amount of time you need to leave between
Yeah,
the
no.
different drops?
Yeah, so like I said, say for instance, the prostaglandins, which is the first line treatment, the evidence have shown they are more effective if you take them on in the evening after 8 o'clock. It's just the way the medication works, as opposed to the beta blockers or the timolol. Some drugs, the lifespan of the medication itself is only 12 hours. So you have to take them 12 hours apart. So if you're going to take them at 8 o'clock in the morning, you will then have to take them again at 8 in the evening. There's no point taking them at 4 in the afternoon because the effect of the morning dose is still in the eye. And then the 4 o'clock dose will wear off way before you then take it again in the evening or the next morning, essentially. So if it is a drug that's prescribed to be taken twice a day, then it has to be split equally throughout the 2 doses, and normally is 12 hours apart. So I normally advise patients is you take it, most people tend to be awake for about 10 to 12 hours. So you take it first thing when you wake up in the morning and last thing when you go to sleep at night. And that usually gives you the 10 to 12 hour break in between. And if the drug itself, like a prostaglandin, is meant to be taken just once a day, then it is meant to last for that whole 24 hours. But again, always try and take the drug around the same time. So there's no point one day taking it at 5 o'clock in the afternoon and the next day taking it at 10 o'clock at night, because the efficacy of the drug itself is only got so much of a lifespan. So you can do that maybe once or twice, but not on a regular basis. And as with all medication, the thing about having a regime and a routine is essentially it makes compliance easier because you just get used to it. This is what you do. You go wash your face, brush your teeth, your drop is next to them, you put your drop in and you go to sleep. And like I said, again, most people tend to go to sleep around the same time, unless they have different occupations and stuff. And for a lot of the tech savvy patients these days, there's plenty of apps, of reminder apps that essentially have alarms set on them that tell them about it's now time to take their drops. And there's lots of drop aids and lots of kind of application programs out there that helps people with their drops if they are that way inclined.
We also have a lot of information on our website around drop aids as well. So if anyone needs help with that, we're certainly here to help. So for somebody who is about to start fasting for Ramadan, why might they have concerns about taking their eye drops during the month?
I think it's the same principle again. So again, obviously the idea of fasting is you don't have anything to eat or drink, and that is absolutely nothing to eat or drink between sunrise and sunset. But the General Council of Muslims and Islam within Britain has issued many kind of informations about medication. And again, in Islam, it's always been designed as a religion to make life easier for people and not more difficult. And it very clearly states in the Quran that if you require to take any form of medication, you should, and that takes precedence over any kind of fasting. Having said that, it has been very clearly documented that topical medication or drops do not break people's fast. So that is the main concern that people have, that if they take these medications, their fast will be broken and it won't be counted. And that's definitely not true. The drops essentially just go inside the eye and they get absorbed within the eye as opposed to go anywhere else in the body. One other way to ensure that happening, because some people do have some drops that essentially can trickle into the back of their throat, because any excess drops tend to get absorbed by the tear duct, which then drones into the back of the nose and into the back of the throat. Patients are advised, and anyway you're advised to do that to try and reduce absorption, to press on them, I'm just going to take my glasses for a minute, on the side of the nose before actually applying the drop. So just make sure you're in the right position, just on the sides of the nose. Put the drop in and hold it for about 20 to 30 seconds. So any excess drop can just wash down the face as opposed to go down into the back of the throat. And that again reduces the chances of reabsorption if anyone has any concerns about that. But I think that is the main issue when it comes to fasting and taking drops, is the worry that the medication will break fast. And like I said, there's been a lot of documentation about this, and it has been confirmed by many of the scholars and the Islamic schools out there that it will not break people's fast.
Okay. And if somebody was concerned and had decided not to take their drops, what impact would not taking your drops for a few weeks have?
A lot. And again, it depends on the severity of the disease, but it just, as with any medication, and as we first said at the beginning of this interview, any damage that happens is irreversible. So that is always the big worry about these things, that if you don't take your drop for a period of about 3 weeks, 4 weeks, which is the length of Ramadan, it would have washed out of your system and the drops are no longer effective. The eye pressure will go up, it will damage the optic nerve, and the damage is irreversible. And you may find that actually you are in a place where the glaucoma was very well controlled, everything was ticking on really nicely, and you were considered like a stable patient. And then if you stop that period, the medication for that period of time, then unfortunately the disease progresses. And then when you go back and decide to take medication again, you'll be finding either you're taking more medication or your doctor's saying to you, actually, I'm not sure the drops are enough and we need to consider something else. And I think the other thing to keep in mind is, for most of us, God willing, Ramadan comes once a year. It's not just a one-off thing where you just do it once in your life and that's it. You know, you will be doing this in a young adult's life or an older patient's life. It's done at least, 30, 40, 50 times, within their lifetime. And that has a cumulative effect. So if you decide, right, that's it, I'm not going to take my drops for Ramadan and it's 4 weeks and it's fine, just think that it's 4 weeks multiplied by 30 years, 40 years, 50 years. And again, glaucoma is a disease of the aging. The older you get, the more aggressive glaucoma gets anyway, the more sensitive the optic nerve gets, the more damage you will sustain every time you decide to abstain from taking the medication.
And if somebody who maybe has an older friend or relative who they're concerned about not taking their eye drops, is there any advice you could give to them for how they could help or encourage their friend or family member to take their drops through Ramadan?
Yeah, I think exactly like you said, there's lots of information out there. The Glaucoma UK information website is great. I've had a look myself. There's lots of really useful information leaflets and in many, many languages, if language is a barrier, for instance. But I think it's reassuring everybody out there, coming from someone, like I said, I fully and completely understand and sympathize people's desire to keep their fast in every way and trying to avoid anything that can break it. We do have a lot of support from all the religious powers and scholars that say this is not something that will break your fast. It will not have an impact. And like we talked about, applying pressure on the side of the nose, making sure that you're not taking, nothing is getting draining into the back of the throat will help. And also the frequency of the drop. So if you are still very, very, very concerned, like I said, as we know, the length of fasting happens from sunrise to sunset. Even though it is not ideal, you can take your medication essentially during those periods of time. So have a discussion with your doctor if you are one of those people who is on a number of medications throughout the day, whether or not that regime can be adjusted. So you can just take one drop in the evening when you break your fast, for instance, if that makes it more reassuring, or maximum 2 drops. So one when you are having the food just before sunrise, and one in the evening when you break your fast. So amending your treatment regime to make you more comfortable. So like I said, I know these things are very easy said from this end, but sometimes, exactly like you said, for an older generation who have their own education, have had their own upbringing and their own beliefs about these things, we do need to be flexible with our patients as well. And I've had this conversation with many of my patients before to look at, well, can we amend the treatment and see if we can just tweak it in a way that makes them more comfortable, and therefore they only take their drops when they are not fasting during that period of time. And that can definitely be done.
Excellent. And that'll probably be really reassuring to some people who aren't quite sure what they should be doing. And that's great to remind people to discuss it with their doctors. And also, again, we have lots of information on our website, and you can call our helpline if somebody's concerned or wants a little bit of advice about how to manage those drops through Ramadan. Thank you, Sally. That's been really, really helpful. Thank you so much for joining me this evening and answering some of those questions. I'm just going to finish off just talking you through that as I promised, at the start, putting that information on the page there. Our helpline number is up there. You can call our helpline Monday to Friday, 9:30 till 5 o'clock. We also have an email address for our helpline there, helpline@glaucomauk.uk, and our website address, www.glaucoma.uk. For anybody who is using social media, you can link in with our Facebook, Twitter, Instagram platforms, LinkedIn, and see all of these messages there as well. So if you are concerned, we are here to help you. As Sally said, do contact your consultants as well if you're worried or have any questions. But again, thank you, Sally, so much for joining us this evening and for answering those questions. And we do hope that you'll come back again another time.
Thank you very much.